AWP Voices, your People Promise in action.
Welcome to the third edition of AWP Voices with me, Steve Walker, and Katie McManus. In the first part of today's podcast, we'll be joined by Mark Batterham, a mental health nurse from Early Intervention Services in Bath and North East Somerset. Mark's also started a secondment with Research and Development, and we'll be exploring that a bit later in the podcast. Mark was recognised as an AWP Award winner in 2024 in a category of Quality Improvement, Innovation and Co-Production. It was Mark's initiative and dedication that led him to lead a project to explore a gap in knowledge and understanding about the impact of urban and built-up environments on those experiencing psychosis. Mark's project led to improvements in widening our clinical understanding and knowledge base around psychosis and the urban and built-up environment. Lynda, Teagle and Katie Smith from the Forensic Community Learning Disability team were recognised in the Involvee of the Year category in the AWP Awards of 2024. They'll be here a bit later at around about the 22-minute mark to tell us about the Service User Forum in part 2 of this podcast. Finally, Katie McManus will round up this episode with news of the People Promise programme. Mark Batterham joins us now. Mark, welcome to AWP Voices.
Thank you very much.
And can I begin by asking what inspired you to investigate the link between urban environments and psychosis?
Okay, so it was a mixture of practice and theory, really. I've been a mental health nurse since 2008, and before then I worked with homeless young people on the estates of North Bristol. And through my practice in my youth homelessness job and my first nursing job, I spent a lot of time out and about with young people, working with them therapeutically in their own areas. And then when I started working in the Bath and North East Somerset Early Intervention Service, I initiated a walking group for our service users. We've been running that on a regular basis since 2018. And aside from that, I also have got a very, very strong interest in the built environment. I studied housing in my early 20s, and then I returned to study more recently, where I studied urban planning at the University of the West of England, through practice of how we practice our day-to-day clinical work and our walking group. And the knowledge I gained from my studies, became aware and interested of the importance of place in promoting positive mental health and supporting recovery. So I started to look into it, investigate it in my own time, found that there's something called the urbanicity effect. And the urbanicity effect was picked up in the late 1930s by a couple of sociologists in Chicago, where they looked at they gathered data, or collected data from what they call incidence rates. That's new cases of psychosis in the Chicago area in the preceding years. They put a pinpoint in the map of Chicago for the address of every person diagnosed with psychosis during that period. And what they found is what's spatial clustering, so clusters of cases in particular parts of the city. And when they replicated that with other severe mental health conditions, they didn't find the same patterns. So there's something about psychosis living in urban areas, in particular urban areas, that raises, if you live in those urban areas, it appears to raise the risk of developing psychosis in the first place. So that was in the States in the late 1930s, and we've had getting on for 80 years of research since then to try and understand the urbanicity effect. Why does living in urban environments and certain urban environments raise the risk of psychosis? What we've had less of is how it impacts on recovery. So once you become unwell with psychosis and then you're recovering, as most people do now in the community, and most people do live in urban areas, how does that impact? How do the social environmental conditions impact on your recovery? I think we're ideally placed in mental health services because we have our relationship and with service users and our work to investigate that together.
Do we know why there might be a link between the urban environment and psychosis? Because in some respects, if you're living out in the countryside, you might be on your own, you might be in a small village, but if you're living in a town or city, you can see your friends more often, you can get about more. So you would think that would bring you close together and you'd have greater connectivity, or is it more likely that there'll be much more stimulation in terms of sensory stimulation in a city, which may lead to you to be more at risk of developing psychotic episodes?
Yeah, you raised some really good points there, Stephen. All of the above apply. I'd say it's really important what you first said, not to be drawn into sort of false dichotomy of rural good, urban bad, because as you articulated. Living in rural areas can have its challenges as well. I suppose in terms of the urbanicity effect, which we now often described in the literature as urban stress, that can be a mixture of sensory stimulation or overstimulation in terms of the visual, auditory, even olfactory, the things we smell. It can be multi-sensory experience, sense of crowding, presence of strangers, threat perception from so many other people that you don't know, being in close proximity to you. So, I mean, the research I mentioned, we've had about 80 years of research into this phenomenon, but still, the consensus is that it's down to a number of factors. One of the most powerful is found to be something called social fragmentation, which is different from deprivation. It's not as simple. Just as the poor areas have got higher levels of psychosis, it does have an impact, and also density as well has an impact. Social fragmentation seems to be one of the more powerful factors, and that's to do where social bonds and social ties are perhaps weaker, higher turnover. If you look at how social fragmentation is measured now in the UK, one of the measurements is actually the extent of private rented accommodation, because people tend to live in private rented accommodation for relatively short periods of time because of the security of tenures. So you have a quite high turnover. So people passing through places, transitional neighbourhoods, not as socially cohesive as more settled areas. So, and if you think about psychosis and paranoia, feeling unsafe, scared, if you've got a continual parade of strangers, I suppose, for want of a better term, that's going to present challenges to forming meaningful relationships and feeling safe and a sense of belonging.
Is there anything you can do to counter the effects of urbanicity? Because if you're in a part of a city where you're getting a lot of stimulation, there's a lot of noise, a lot of bright lights, a lot of hum of traffic and everything else, is there anything you can do to sort of, counteract the effects of...
Yeah, and I think once you start thinking about this and observing people, you can see what we call tactics, people's tactics of the city, how people commonly now listen. You see lots of people with headphones on, and they're shutting out. My colleagues, we've developed a really good collaboration with colleagues in Switzerland, and I think they frame this as what's called bubbles of isolation, where we shut out the external overstimulation and retreat into what's more manageable and comforting, listening to your favourite music with headphones on, scrolling on your phone because outside is too overwhelming. So we retreat into what's comfortable. So we put these sort of safety behaviours in place, or not always safety behaviours. In many ways, they're a necessity of managing life in the city, really. Yeah, so there are ways of doing that. And then that's from sort of individual approach. But of course, there's a whole discipline here that's concerning this. Urban planning came out of public health in the late 19th century. We had the first garden cities in this country. Letchworth, Welling, developed in the early part of the 20th century, and they were interested in healthy places and bringing the positive aspects of the rural into the challenges of city living. How can we blend the two to provide healthy places where we can provide spaces for respite, relaxation, cultural engagement? So how do we design our cities and our places so that they're tolerable and enjoyable, so people don't just cope but thrive? So it's a key thing and a key acknowledgement that we need to reach out to and think about it from changing the environment as well as supporting people to manage individually. So we've got really good collaboration with our colleagues in the planning school at UWE that continues, and that's really important to retain. So
how did you go about developing your research project?
So it started off with a bit of, like I say, a bit of reading and myself chatting to colleagues about it. So how it started off, really, we decided to evaluate our walking group because we realised that the benefits of our walking group extended beyond its initial aims. So we thought it'd be really good to try and capture that. So we developed a collaboration with a geographer at Swansea University, Dr. Aled Singleton. He's now at Cardiff University, and he helped us to evaluate the walking group. We did interviews with staff, interviews with service users. We used maps, photos. It took us 3 years. I'm slightly embarrassed to admit, but it was over the pandemic. That's my excuse. And AWP supported that through the locality quality improvement facilitator. And that got us, I suppose that got me into the research mindset, opened up some new collaborations and links, and it brought up some interesting points for us to explore further. So we actually presented the findings from that evaluation at the Royal College of Psychiatrists with one of our service users and one of my colleagues, Rich Gurney. I think that was last year. And that then brought broader investigation into this matter of urban living during recovery. So the service evaluation I did was actually done in my own time, which is probably why another reason it took so long. You're sort of squeezing it in when you can between busy clinical diary. But obviously to do a proper research project, you need time, you need space to do that properly. So AWP got a small fund called the Research Capability Fund, and they funded me to initially do a review of the literature, which I completed with some colleagues, and was fortunate enough for that to be published. And then from there, I applied for a NIHR, which is the National Institute of Health and Care Research, a fellowship, which is specifically designed for non-medical staff to get there to initiate research careers, I suppose. And it gives them time, space, training to look at an area of clinical importance and interest. So that gave me some, starting with the AWP funding, and then the funding from the NIHR gave me the time and space and support and extra skills to develop this further. And it was during both of those, we started to engage with service users around this and carers.
You've had input from service users. How valuable was their lived experience in aiding your understanding?
Hugely, I'd say. It happened at different stages. So the first phase of the research process is a sort of conception stage where you're clarifying what exactly are you investigating? Is it of relevance to service users in their day-to-day lives? Is it meaningful? Is it important? So those conversations are really important. One of the service users actually helped me facilitate conversations with service user groups and carers. I can remember one service user group we had actually on REI allotment in Bath, which is a nice and fitting way to have that discussion. It's a green oasis in the city. So we're sort of checking that we were on the right track, checking it was meaningful and acceptable. And then beyond that, sort of more formalised service user involvement is during the design stage. Gate research can take a long time, years. It's quite different from clinical work in that respect, and many others. But so we had a year to design the study. I was learning myself very much, so we had some guidance from academics at the University of Bristol would be really helpful, and others as well. And so we recruited from the Baines EI caseload, actually, we recruited a group of 5 service users to help with research design. So they formed a group and they referred to themselves as a service user research group. We met regularly as a group at AWP's base at the Swallows in Poulton. They've got a nice group room there, and we met normally in the evenings because people got other commitments, work, studies. And we met there and we designed the study together with guidance and advice from academics and subject specialists. So they were integral really to designing the study and putting the application into the NIHR for funding. So I'll give you a couple of examples if that would be helpful of how they got involved.
Sure, yeah.
The design we decided on is called an exploratory sequential design. So sorry, that's a bit sort of research jargon. So what that actually means in layman's terms is there's lots of stuff we don't know here in this respect. So it's exploratory in that respect. We're not working with a really clear hypothesis which we're testing out. We're curious. It's a more sort of inductive process. We're curious about what we're going to find and open to new information and discovering things we hadn't thought of. And it's sequential in that we're going to do it in certain stages. And we're starting off. One of the first things we're going to do is a qualitative study with AWP EI service users who are currently living in urban areas during the period of recovery from psychosis. And we're going to interview them. We're going to do mobile interviews, what's called go-alongs, where you walk around, the service users lead the walk around their local areas, and we ask them questions about that. So what does that look like? I've never done one before. I've only recently found out what they are. I've read some examples. We've got some really good advice from some other researchers, but we wanted to, what questions are we going to ask? So we wrote the questions together, me and a couple of the service users. The service users actually divided into 2 groups, according to their interests. So the group that were working on the qualitative study with me, we looked at a model which we were going to use, a theoretical model. We wrote a topic guide, interview topic guide together. And then we were really pleased to be able to pilot it with a healthy volunteer, young lad living in East Bristol in an urban neighbourhood, recently moved there. And the service user researchers helped me pilot it. And it was great. It was really interesting. We all learnt so much, and it's really helped us to develop the method and the approach. So they're input, their involvement, their enthusiasm and their reflections and insight were really great and really helpful. But just one other example I'd like to use as well is around language and the language you use, particularly around mental health. And some language can be stigmatizing, some can be hurtful, discriminatory. Really, really helpful to have their input around framing things we talk about trauma-informed care, and therapeutic language is really important to take that on board. And who better to ask than people that have been through their experience themselves. So if I might say, Stephen, one thing we didn't do, which was key, is we didn't ask them to disclose their personal experience of psychosis. This wasn't about them giving their testimony of psychosis. This was about utilising their lived experience, what they'd been through, to help develop and inform research design.
How's being involved in your research project help with service users' confidence and skills?
Well, I'm a bit reluctant to answer for them, but we did have, towards the end of their involvement, we did actually have a reflective discussion as a group with my colleague Hannah Antonio from Research and Development. Hannah came over to the Swallows she wanted to hear, which is really great that, Hannah is a senior member of the Trust, interested, it's a really good message to Service User Research Group. The Trust are really interested in hearing about their experience. So Hannah facilitated a group discussion. I took some notes. So they spoke about feeling intellectually stimulated, about being empowered, feeling trusted to be creative. I think some specific examples we put at the beginning, we took care to meet individually with all of the service user researchers to develop an involvement plan with each of them. What would they like to get out of this project? Obviously their involvement's helping the project, but how can the project help them? So they all wrote a plan for their own development. What did they want to develop? Key skills to develop, knowledge they wanted to acquire. So we structured the work around their individual plans. So I know one of them wanted to feel more confident in public speaking, and she, obviously very anxiety provoking, but she presented, really without me doing much at all other than setting up the meeting. She presented to some senior social care managers in Baines about the project pretty much on her own. I had a question from the audience. I was struggling in my answer, and she came in and answered it much better than I could. So it's interesting the way they view, maybe service users, how they change, how they view themselves, how that shifts from being a recipient of care to being an active participant in research, and how other people may view them as well.
Is this a real example of co-production at its best, would you say?
I met a fellow recently from the University of Bath, and he works in this area, service user involvement. He introduced me to this thing called, I think it's called Spectrum of Public Participation. Sounds like it's a heavy metal album, doesn't it? So, so I had a look at that, and I was thinking, where does this sit on this spectrum, really? And I think it's pretty high up. It's sort of collaboration, I'd say, on that, really. So you're definitely involving people in the process. They've got a real say in it. I think some reflections from me, I think the service users operating together as a group meant that they had more power than as an individual. And I also think that the discussions they had with each other was as, if not more important than the discussions they had with me and other sort of paid researchers. So
last year you published a paper in the Journal of Mental Health Practice called Urban Influences on the Development, Perpetuation and Mitigation of Psychosis. So do you feel you've started to add to the evidence base about urban environments and the link or the impact they may have on psychotic experiences?
Not at this point, no, to be honest. I think that was really bringing together other people's work hopefully in an accessible way, and bringing it to a new audience, which is basically frontline mental health practitioners. I think it's putting it on the radar of the importance of place and space to mental health and to recovery more specifically. So I think that was deliberately targeted at that sort of journal, because it's read by actual practitioners. It's not just read by an academic audience. So,
but do you think in a way you've put the pebble in the pool, you've sort of started the discussion?
Yeah, definitely. And it's ongoing. It's ongoing. I'm really pleased that our application for our research design went in, the application for funding to the National Institute of Health and Care Research. And I was really pleased that was successful, which is a real, testament to the work the service users put in, but also everyone else, I think, including my colleagues, people from R&D. I really like the term. I mean, our approach was informed by something called participatory action research, which is sort of based on, it's got a few guiding principles, one of which being social justice, really. And I really like the term that's sometimes used in participatory action research called communities of inquiry. And I think that's really nice that we can bring together groups with lived experience, with professional experience, with some technical specialist knowledge. So working together, bringing those areas of knowledge together can form this community of inquiry. And we've got more to do, more to find out. Who knows what these interviews are going to bring up? It's really exciting, if a bit daunting. So I think, very soon, we're going to start generating some primary data, and we're going to be sharing it. We're going to be presenting it, and we've also got money this time from the NIHR. They're funding service user involvement on the next stage of this process. So we're going to be recruiting a new group of service users to help us.
And of course, you've got a secondment role. How is it a secondment role with research and development? You've got some sort of fellowship role, haven't you? That's going to come to fruition this year. That's
right. Just started at the beginning of September. So I'm going to be doing a bit more training in research methods, research skills. But most of it is going to be spent on delivering the research project that we designed together. So this is the biggest, longest phase of research, the delivery phase. It's quite unusual still for AWP to conceive of, design, deliver a research project, to go through the whole research process. Most of research activity in AWP is supporting delivery of bigger national projects, sometimes regional, national, sometimes international projects. So it's unique, fairly unique. It's exciting.
Well done, Mark. Thank you for being a guest today. Lynda Teagle and Katie Smith are here from the Forensic Community Learning Disability team to talk about the Service User Forum. So, Lynda, would you like to tell us about the Service User Forum?
So we work with people with a learning disability and who often may have additional comorbidities. The people that we work with are individuals who may have a history of offending behaviours or may be at significant risk of offending behaviours. So we work with them through direct interventions and assessment work, and also work with support systems around them to provide consultation and advice. We work with people, a multitude of...
what kind of reasons are those?
So the factors really that may have led them to have got into trouble with the police, the contributory factors, helping them to move to a life that's less involved with criminality, supporting them and supporting the providers to reduce risk and risk factors that may have contributed to a person's offending history. We established our Service User Forum approximately 9 years ago, and that came out of a place where we wanted to gain the advice and support of the people who've used our services so that they could tell us about what was good, what wasn't so good, where we could make improvements. I think the first piece of work that we did with the forum was to look at our information leaflet and to gather their views. Was it meaningful? Did it tell them what we did as a service? Did it, give them advice about what they could expect from us? So they gave us some really good feedback on that. They told us that the leaflet was great. It explained what we did, but it didn't really tell them how to get to us. So they came up with some suggestions that we hadn't anticipated. So things like, could we have a map that explains where the building is? Could we have a route planner that tells us how we might get there? So I guess for us, that was kind of the first piece of work that we embarked on with the forum. And it just kind of opened up our eyes really to the fact that we might anticipate that people are able to feedback in different ways than we may have thought. Our forum, it's grown. It's a very small part of the service that we offer. It's for people that have previously used our service and who maybe want to give a little bit back, want to have a voice, want to be involved, be pro-social, move away from a life that was less social perhaps. So we found that over the course of the years that we've been running the group, that members have kind of really been committed, they've really been engaged, they enthuse and inspire us really to kind of keep it going. We hold our meetings on a monthly basis, and those meetings have continued throughout a 9-year period where we had, a huge episode of disruption in the middle with the pandemic. But our service user forum members were really keen for us to continue with that involvement throughout that period of lockdown. We had to be creative. We had to stick to the rules. And so I think we met in parks, for example, groups of 6 when that was an essential guidance from the government. But the group were really motivated to keep on going, and that really enthused and motivated us to keep on going. The connection that the group has, the commitment, I think it's really inspiring. And I guess whilst the forum was developed to support us as a small service to look at how we may make improvements, I think it's grown, and we get a great deal of requests from other services, from the organisation, from external organisations, to support them to consider how what they're doing is meeting the needs of the population that they're working with. I think one of the greatest things that our forum helps us to do is to look at easy read information and to support us to make things more accessible and more meaningful, to cut out the jargon, to cut out the acronyms, to
Who can get support from the forum?
So our forum is open to people that have worked with us in the Forensic Community Learning Disabilities team. So after we've provided any therapeutic intervention work, which can be like any length of time, really. So it's once that work is completed, then we invite them to join our forum, join our service user forum. So it's very different from working with them throughout as a therapeutic interventional kind of work. It's after that. It's kind of a different
kind of care pathway in a way, or I guess support. Yeah, absolutely. Yeah, I think it's a different relationship from the therapeutic relationship that you build at that point when someone's come into the service. And it's to build further confidence in the community and to hear people's voice when after they've gone through the process of working with us. What tends to happen when you have a get-together of the forum?
So we meet every month, once a month, and it's very busy. We've pre-arranged the date, so it's already, we think about when we're going to meet 6 months in advance, so we already know. It's very busy, it's very noisy, there's lots of chatter and lots of welcomes and lots of cups of teas and coffees are made. And we sit down and we have a welcome. We try and do has anyone got any good news? We go around and everyone tries to share a piece of good news or something that positive that is happening for them in the week coming, or something they're looking forward to, and any introductions that there might be. And usually we do have visitors, as Lynda's just said. Visitors come to our forum to share their knowledge, our forum members' knowledge, and try and in their learning and improving their service, or breaking down boundaries with some of the visitors that we do have, members of the community police officers, and as such. And then, we have those conversations with our visitors, really. We spend about an hour and a half together and we confirm our dates for the next session, for our next meeting, and that's it.
So it
goes very quickly.
Is it quite a social affair?
Yeah, absolutely. I think so. I think our members, some of them know each other outside and inside the forum. So it's a good social opportunity for them. And they've built up friendships outside of, the work that we've done previously. They've built up friendships and things, and they've gotten to know each other really well. And it's been a bit of a platform for that.
People join the forum when they've kind of ended their episode of work with us. So they've completed their therapeutic intervention.
Yeah.
And they are wanting to kind of stay on track. They find that remaining involved with us, I think, is supportive. And I guess anecdotally, we don't see a lot of people that are members of our forum getting back into trouble and coming back onto the caseload. So I think it is helpful in that direction. It gives people some structure. It gives people an opportunity to be a part of something. Often we find that the people that we work with can be really isolated, really marginalised. They may have networks that are less kind of pro-social. This is an opportunity, I think, for people to be part of something that is pro-social. It's something that I think we've seen people develop their confidence over time. We've had people coming for many years that maybe started coming at a time when life wasn't great, and their confidence wasn't great, but over time that's grown. They've developed. Some people have had jobs. Some people need to dip out of coming to the forum because they're engaged in more regular activities and work, which is really, really positive. I think we've seen that members of the group kind of lead the group to some extent now, whereas we started off being quite directive. The forum is owned by its members now. They will generate ideas. They will say, we'd like to meet with this person. We'd like to hear more about that service. We'd like minutes for our meetings. We'd like to read the minutes. We've had people that would like to write the minutes. So it kind of feels that it's over time become much more collaborative. The co-production within the group has grown over that period of time. I think, we've had some members that have been coming for many, many years, and we've got one member who has sort of recently joined about a year ago, I think.
So what's next for the forum?
I guess we've had a really busy year so far this year. Some of the activities that we have been involved in have been meeting with other professionals. So we met with the police, we've met with the fire service, we've been involved with sort of supporting some psychiatrists with developing accessible information. So we've been giving some feedback on a project that is looking at accessible information around medication. So a video, and we've been kind of nitpicking, I guess, is what our forum's really good at, nitpicking and advising. We met recently with the National Development Team for Inclusion to support them with a piece of work that they're doing locally. They're researching what is important for people with a learning disability and autism in terms of resources and activities that are local, what's needed from health services, from social care, from employment services, from housing. So our members have been able to give their view, to share their experiences, to share their thoughts, their dreams, their wishes. That was really informative for us. I think we learned that there were things that we hadn't considered. Some of the barriers that people experience, for example, to getting into employment, getting into housing, getting into the right housing, having the right support, having their needs met. And I guess those are all factors that we know will lead people into offending behaviour. If those things aren't in place, if that support isn't right, our members are really vulnerable, and they can be quite easily led into situations that they don't fully understand, that the implications are not fully understood, the consequences. Having support, the right support in place at the right time is absolutely vital. I think one of the things that we've learned from our forum members is that it's okay to ask questions. It's really good to ask questions, in fact. and people will tell you quite happily what their experiences are. They will give you advice about changes. And I think it's really important then to come back and to explain that you have listened, you have heard, and these are the changes that have been made. This is what your contribution has helped us to change. So kind of, really encouraging and embracing the involvement of others to influence and impact on change in our services.
Katie, do you have any thoughts for the future about the forum?
I think it's just going to hopefully keep growing, and I think we'll keep providing one of the newer elements that is supporting other providers of health and healthcare in creating their own service user forums. And I think to keep enabling that to happen and that platform to take place, and keep listening and valuing the thoughts and feelings of those people that we support, I think, hopefully that's where we would like to go and keep learning.
Because I guess you're always learning.
Yeah, we're always learning. Absolutely.
I guess the people that attend your user forum will have ideas, suggestions, and ways of doing things that I guess you haven't thought about.
Absolutely. I think we don't have that lived experience. So to hear it from people who do have the lived experience of using our service, of using mental health services, of having a learning disability, and being able to help them access what they need and understand and build confidence. That's we want to happen, really.
Lynda Teagle and Katie Smith, thank you.
Hi, Steve. Thanks for having me back again, and welcome again to our guests. Thank you for everything you shared so far. It's been really great to listen to information about the projects and about the research and the groups that you're involved with. And the People Promise that I'd like to talk about just for the end part of this conversation today is we are always learning. So we know that there are many opportunities for people to learn and develop. It's not just going on a training course or applying to the Workforce Development Fund for something that's formal. Learning comes all day, every day. It comes from conversations with colleagues. It comes from attending meetings and, of course, listening to our service users and seeing what we can learn from them. And I wondered, as I was listening to you talk, what opportunities there have been for you to share the learning that you've had from the work with your service users.
So we were recently, our service user forum were invited to support a psychiatry conference. And as part of that conference, some of our forum members sharing their knowledge with other care providers nationally, actually, from all over the country, health and social care providers. And I think that was gave a really good broader platform for the forum to be able to share what they find is really their thoughts and feelings about, care provision and ensuring that they're heard throughout.
I think that must have been, I'm making an assumption here, but a really empowering experience for them as well. Probably quite an intimidating experience, but really rewarding as well. I know that when I met a range of your service users that used the forum at the annual awards, they were absolutely delighted to be there and to win Involvee of the Year for the work that they do, and felt really humbled by it, but really, really keen to continue to engage and to help and to inform where they can, and to use that lived experience to encourage people to continue to learn and develop and offer the best care that they can. So other than that conference that you mentioned, have there been any other examples that you might like to share with us today?
Across specialised services, there's a really strong commitment to working with people with lived experience and valuing that lived experience. And there are sort of lots and lots of opportunities where that is shared. So there's a lived experience hub that gets involved with many, many projects. Service users are represented from across specialised services. So getting involved at all different levels, getting involved through participation at meetings, from going off and doing projects, etc. Specialised services also recently held a fabulous event this year, which was Lived Experience Celebration Day. And we had amazing contributions from people that have used a variety of our services. So from people that have been involved in accessing the liaison and diversion services, the prison services, the eating disorder services, the perinatal services. So sharing their experiences with the wider service. It was a fabulous event, and I think those types of opportunities are so meaningful. They're so valuable. They're not, I can't think of the word. I guess they're not tokenistic. They really are an opportunity for sharing and learning and from one another and the people that we provide our services to.
Thank you. That's a fabulous example. And actually next month in November, there is going to be a festival of learning, and you'll see comms coming about that fairly soon, where we're going to be celebrating both learners within the organisation and those that help facilitate their learning, the people that are assessing, that are mentoring, that are coaching people, that are really helping to develop that learning culture. So yeah, big shout out to Specialise there for their celebration day. And how about you, Mark? Do you have examples that you might like to share with us?
Yeah, I've got a couple from the Psychosis and Urban Living project. The first one, last year I was fortunate enough to go on a research visit to Switzerland and visit a research centre in Switzerland that have done some really interesting early research around urban living and psychosis recovery. The main purpose of the visit was for me to learn from them, and there were great work they've been doing, but they were keen to hear from us as well. And one of the areas I was pleased to hear that we seem to be doing comparatively well on is service user involvement. So I gave a short presentation to their research group on service user involvement in our project, and they were really interested in it and inspired by it, keen to find out more. And we're hoping actually that one of the Swiss researchers is coming here soon, and AWP will be able to help host that visit, and it'll be mutually beneficial and interesting. So that was one example. And the second example is actually AWP Research and Development Department. We're really great at funding service user involvement beyond the submission of our grant application for study funding. And what was good about that, it was an acknowledgement of the importance of sharing and celebrating service user involvement, and having given service users opportunities to have their names on outputs. So there was a few outputs in that period, and currently putting the final touches to a case study with one of the lived experience researchers, which is hopefully going to be published on a website. But something which involved the whole group, which was really great, was an art exhibition. So one of the lived experience researchers led some workshops, art-based workshops, where they reflected on their developing a particular method for our research design, things that had inspired them, their reflections. We produced lots of pieces of art together as a group, and they were framed and exhibited at Birdall's Yard in Bath this summer. We had a really nice celebration event with service user researchers attended. So colleagues from research and development there, some clinical colleagues, some of our collaborators came. It was a really nice event and a really good way of, it was sort of an ending in a way because of that, the design phase coming to an end, but an acknowledgement of the work they put in, but also celebration of meaningful lived experience work, really, and what can come out of it.
That's great. Thank you. Another example of a different type of celebration, but one equally as worthy, and enabling people to share their learning and to really spread what they've got out of these projects, and both the Service User Forum and the Urban Psychosis project that you've been leading. It's been really, really interesting to hear all about your work today. Thank you so much for joining us. It's been a pleasure to meet you.
Before we go, it's important to note that Mark secured a 1-year National Institute for Healthcare Research pre-doctoral clinical and practitioner academic fellowship for his research design work. He's just started a National Institute for Healthcare Research doctoral clinical and practitioner academic fellowship. Both fellowships were and are hosted by AWP in partnership with the University of Bristol. If you or your team would like to take part in AWP Voices, please contact Katie McManus. You can email her at katie.mcmanus1@nhs.net. For me, Steve Walker, goodbye for now, and we'll see you soon. Take care.